Good morning, everyone. Hope you're doing all fine. I'm Gerald de Vigeron, a micro-HSP professor, and I am tasked to deliver a lecture on bones and cartilages. At the end of this lecture, these are our intended learning outcomes to differentiate the types of bone, to describe the different types of osteoid cells, discuss the Aversion System, or the osteon, to differentiate the types of cartilages, its trauma, and its growth, and to discuss the common clinical conditions affecting the bones and cartilages. Right, let's talk about the bone first. Generally speaking, when we say bone, the functions are the following. It provides us solid support, protects us the vital organs, especially the rib cage, protecting our lungs and heart, and also the brain, no, the skull or the cranial bones protecting our brain. It is also serve as attachment for muscles, tendons, and ligaments, and it also acts as levers. Bones also is a reservoir of different types of ions, such as calcium, phosphate, and other ions in our body. But before we discuss the bone itself, let's talk about the cells in the bone. All right, the first one is the osteoprogenitor cells. When we say osteoprogenitor cells, they are undifferentiated cells that are capable of mitosis. This is also known as your mesenchymal bone cells. Okay, osteoprogenitor cells are also known as your mesenchymal stem cells. They have the potential to proliferate and differentiate into the next type of bone cell, which is your osteoblast. And also, this type of osteoprogenitor cells, they have role in bone growth and repair. Next would be the osteoblast or the bone-forming cells. Basically, their function is to synthesize what is known as your osteoid. That is the organic component of the bone matrix. So, in other words, osteoblast, bone formation. Okay, osteoblast, osteoid synthesis. Now, the osteoblasts are found at the lining surfaces of the bone matrix. And there are two types of osteoblast. We have an active osteoblast and you have inactive osteoblast. The main difference is that look at the shape of the cell. They are both osteoblasts, but the active osteoblasts are cuboidal or columnar in shape, while your inactive osteoblasts are squamous or flat cells. Okay, like in this illustration, if you look closely in the characteristics of your osteoblast, they align. Okay, they are found at the lining. Now, these are all osteoblasts. The main difference of an active and inactive is or are their shape. Okay, if this one is a columnar or cuboidal, we will call this one as active osteoblast. Now, there are other pictures that I'll be showing you later. If it is a flat or squamous, that means it is inactive. Okay. Now, as a review, osteoblasts here, they line the periosteum. They are involved in bone formation or they synthesize the osteoid. Okay, after osteoblast, let's go now to the parenchyma of the bone, which is your osteocyte. They are the mature cells and their shape is flat and almond shaped with projections. And that projections are actually your cytoplasmic processes. The osteocytes class, they are found in the cavities known as your lacunae. Okay? They are found in between the bone matrix layers and the function of the osteocytes is for bone matrix maintenance or it maintains bone matrix. And in the osteocytes as well, we may find canaliculi. Okay? Bone canaliculi serves as communication or conduit of nutrients in between the osteocytes. Okay, let me show you another picture or illustration of these different types of bone cells. From the previous slide, these are all osteocytes. Okay, they are found in the bone matrix. Now, after bone formation, that's the role of the osteoblast. It goes in the bone matrix, and this now will become your osteocytes or the mature bone cells. If the osteoblast function is to form bone or bone formation, the the osteoblast is for bone formation. The osteocytes, on the other hand, it maintains this bone matrix. Okay, it maintains bone matrix. Okay, this is another illustration showing you the bone cells here and its cytoplasmic processes. If you look closely, this is a high power magnification showing you these finger-like projections. These are known as your bone canaliculi. Their function is it will serve as communication of one osteocyte from another osteocyte, and also they serve as a conduit of nutrients. No? They supply nutrients one from each other. Okay, these are the finger-like projections. As I mentioned, they are known as your bone canaliculi. Okay, and last, bone cell is not actually comes from your osteoprogenitor cell. The osteoclast, they are motile, multinucleated giant cells, and their role or function is basically bone resorption. Okay, bone resorption. They are produced by the fusion of bone marrow-derived monocytes, and basically, when we say bone resorption, they erode the bone matrix during bone remodeling. Okay, again, important note that osteoblast does not come from they don't come from osteoprogenitor cell. They are derived from the monocyte phagocyte system. Okay, meaning they are derived from the bone marrow derived monocytes. Okay, all right. If your osteocyte, no, they lie inside or they lie in lacunae. The osteoclast, on the other hand, they lie within this so-called resorption lacunae or your Howship's lacunae. Okay, this is a structure where your osteoclast are deposited or they are lodged in Howship's lacunae, osteoclast. If it is an osteocyte, they are lodged in lacunae lang. Okay? Okay, this is an example or an illustration of the different types of bone cells. No? As mentioned a while ago, if it is found at the lining of the periosteum, it is your osteoblast. Now, this one is, the B here stands for bone matrix. And what maintains the bone matrix, as I mentioned a while ago, are your osteocytes. Okay, these are all osteocytes. What is that cell called that is derived from the fusion of bone marrow-derived monocyte? Monocyte phagocyte system. This is a motile, multinucleated giant cell called your osteoclast. Okay, function of this cell at the cursor, at the pointer, it is involved in bone resorption. No? Why? This large multinucleated, this osteoclast has three or four nucleus, while in this one, no, it is also multinucleated and it is large. Okay. Okay, this is another slide showing the different bone cells. Okay, these are all your bone osteoblasts lining the periosteum. Your osteoclast, they are multinucleated giant cells and they are for bone desorption. What our OC stands for? The OC stands for osteocytes, and they are found in the bone matrix because their function is really to maintain the bone matrix. Okay, this is a good illustration on the different types of bone cells. This is taken from Junqueira. And as you all know, look at this area right here. These are all osteoblasts. Okay, they are involved in bone formation. And if you look closely, if this one is a flat osteoblast, they are inactive osteoblast. While in this, look at this particular or specific osteoblast. This is more of a columnar or cuboidal osteoblast, and this one is an active osteoblast. Look closely, they will try to penetrate this matrix to become your osteocyte, right? And these are your mature osteocyte which maintains this bone matrix. Okay. Another cell is this multinucleated giant cell called your osteoclast, and that is for bone resorption. Okay. Okay, this is a picture from the laboratory. This is a slide of osteoclast. No, Doc, why is it that the osteoclast is found at the bone matrix? No, as the description of the osteoclast, they are motile, so they can be found at the lining or they can be found inside the bone matrix. But you have to take note that for you to be able to identify this cell, you have to meet the criteria that is large and they are multinucleated, as seen by this slide. Okay, again, what's the function of your osteoclast? It is for bone resorption. What if we ask you in the practical exam, identify the structure that is pointed right now? If it is structure that's pointed, it is your house shapes lacunae. But if we ask you what is the cell pointed, it is your osteoclast. Okay, where it is derived not from the osteoprogenitor cells, but they are derived from the monocyte phagocyte system. Okay, what's the function of the cell pointed? Bone resorption. Okay, this is another picture in the laboratory where your osteoclast, no, this is a multinucleated giant cell, is found inside the bone matrix. Okay, let's apply this in medicine. We have the so-called osteopetrosis. This is a genetic disease wherein it is characterized by having a dense, heavy bones or marbled bones. And the main culprit is that the bone resorption of the osteopetrosis is actually defective. Now, as you learned, bone resorption is defective. What specific bone cell is defective that you are talking about? It is your osteoclast. Okay. In osteopetrosis still, there is an overgrowth and thickening of your bones. As such, there will be obliteration of the marrow cavities, presenting to you with anemia and loss of WBCs. As you all know, if there is loss of WBC, we are prone to infection. And as we all know, if there is anemia, signs and symptoms such as easy fatigability, pallor, those are the common characteristics of being anemic. Okay. All right. This is an example of an X-ray showing you osteopetrosis. But in this picture, this is the normal chest X-ray. Sorry, normal X-ray of the pelvis and of the femur. Right. In osteopetrosis, no, there is an increased bone thickness and density. No, that's why it is it really looks like a marbled bones. Whereas in the normal X-ray, there is this is a healthy bone thickness and density compared to your osteopetrosis, which has an increased bone thickness, and that is very characteristic of your osteopetrosis. Again, the defective cell here is the osteoclast. Okay, let's continue. Let's go to the bone matrix itself. There is inorganic and organic part. The inorganic bone matrix is usually 50%, and the most abundant, the responsible for hardness of the bone is your calcium hydroxyapatite. Okay, but not just the calcium hydroxyapatite that is responsible for the bone being inorganic. There are presence of some ions such as your bicarbonate, citrate, magnesium, sodium, potassium ions, and also calcium phosphate. No, but the most abundant, if asked in the examination, inorganic bone matrix would be the calcium hydroxyapatite. The organic one is composed of type 1 collagen. As you've learned in the connective tissue, the classification of bones are actually type 1 collagen. To be specific, they are of organic component. They are composed of proteoglycan aggregates, multi-adhesive glycoproteins such as your osteonectin and osteocalcine. The organic bone matrix also is associated with minerals that is responsible for collagen fiber formation. That being said, that is responsible for the hardness and resistance of bone tissue. Okay, that is the organic component of our bone. The inorganic component, as mentioned, is because of calcium hydroxyapatite. The organic one, it's because of the collagen fibers, specifically type 1 collagen. Okay. Okay, let's move on. After organic and inorganic component of the bone, let's go to the fibrous coverings of the bone. We have three: the periosteum, the endosteum, the periosteum and endosteum, The periosteum has outer and inner layer. When you say outer layer, they are composed of a dense connective tissue, some of the blood vessels, your collagen bundles, and the fibroblasts. And as we've learned during your lecture in connective tissue, your fibroblasts are actually the parenchyma of your connective tissues. Okay? In the periosteum also of the bone, you may also find Sharpey's fibers. They are perforating collagen fibers that penetrates the bone matrix, and that actually binds their periosteum to bone. So what am I talking about? Let's see in illustration here. The periosteum here has inner and outer layer. The outer layer is composed of this area, your perforating fibers or your Sharpey's fibers, and that binds their periosteum here. That's the outer layer, and the bone itself. Okay, are we clear? This is the bone itself from this tip of the pointer up to this area. But what binds the periosteum, the outer layer of the bone, to the bone itself is your perforating fibers or your Sharpey's fibers. Okay, so as mentioned, your periosteum has fibrous layer, and that's the outer part. Let's go back to the periosteum inner layer. The inner layer, on the other hand, it's more of cellular. No, these are the bone cells that we've learned from the first part of the lecture. The bone lining cells, the osteoblast, and the osteoprogenitor cells. So basically, the inner layer of the periosteum, they nourish the osseous tissue, and they provide continuous supply of new osteoblasts. Thus, because of the presence of the osteoprogenitor cells becoming osteoblast. Okay, that's your periosteum. Your endosteum covers small trabecular bone matrix. They are thinner, and they also contain the different types of bone cells. The bone lining cells, your osteoblast, your osteoprogenitor cells. Okay. Yeah, so this is taken from Junquera. This is an illustration showing you a cross-section of diaphysis of the humerus. So in here, as mentioned, this is the periosteum, and we have endosteum and the outer and the inner layer, your perforating fibers or Sharpey's fibers. And from this tip of the pointer up to this area is your compact bone. Inside is more of the spongy bone. That's the two types of bone, which we'll be talking about in detail in a little later. Okay. All right. So as we learned during the first day of orientation in micro-HSP, we have this compact bone. Okay. The compact bone is the unit is the Aversion System, or what we call your osteon. And this will be discussed to you in a little while. This is just an overview of the Aversion System. Aversion System is composed of the Aversion Canal, and the contents of the Aversion Canal are, let's put it this way, vein, artery, and nerve. That's the composition of your Aversion Canal. Okay, the Aversion System composed of Aversion Canal, and this one are actually your parenchyma or your osteocytes. Okay, let's put it in a high power magnification. This is your osteocyte. They are lodged in what we call your lacunae. The cytoplasmic processes or the finger-like projection are what you call your bone canaliculi. No? And as a review, their function is to provide communication between osteocyte, and it is a conduit of nutrients from one osteocyte to another. Okay. Okay. Let's apply it to medicine. After learning about osteopetrosis, let's go on to osteoporosis. Osteoporosis meaning you have a porous bone. This is evidently common in immobilized patients and some of the postmenopausal women. They are more prone for having osteoporosis. In this medical condition, the bone resorption exceeds bone formation. So from the learnings that we had a while ago, the osteoclast, no, functions as bone resorption exceeds bone formation or exceeds osteoblast. Having said that, the osteoporosis has a reduced bone mineral density as well as calcium loss from the bones. Okay, so in this osteoporosis, if you notice, if you have a reduced bone mineral density, this one will look like the bones will look like, this is the normal bone. And if you have osteoporosis, yung mga butas na yan, no, this one will create they will be reduced mineral content, no, reduced in calcium, so you are prone to fracture in the future if you have osteoporosis. Now, how do we diagnose osteoporosis? We usually diagnose this using essential DXA. That's the most common used bone measurement test used to screen for osteoporosis. We use hip and lumbar spine. No, that's the most diagnostic, the essential dual absorptiometry. Okay, this is usually done. The screening usually for 65 years old and above, but for those patients who have an increased risk for osteoporosis, less than 65, we may actually use also essential DXA. We may actually use also peripheral DXA. Peripheral DXA, not just like the central DXA, but the difference is that for the peripheral DXA, we use the hands and foot, no, to test for osteoporosis. And how do we interpret that? Okay, the DEXA scan, that's the essential DXA, the DEXA scan, the normal is up to -1. Okay, I got this from the American Society of Osteoporosis. Osteopenia is from -1 to -2.49, and the osteoporosis diagnosis is 2.5, -2.5 and above. What's the implication of that? If you have a normal DEXA scan, no, sabi dito, keep living your life. No, you see you in 10 to 15 years for your next scan. So basically, 10 to 15 years would be the screening after a initial screening. And if that's normal, no, that's good. Keep living your life. But if you fall under the osteopenia, turns out you're getting older, what's the recommendation? You return for a repeat scan after 2 to 5 years, depending on severity. Meaning, if you're osteopenic, no, less than 2 to 5 years, if you have symptoms showing osteopenia, no, you may actually go to your family doctor or medical practitioner or orthopedics or rehab doctor for a consultation. But if you happen to be osteoporotic, no, your DEXA scan falls from -2.5 and above, what are the clinical risk factors? You may be at risk for experiencing a fracture. Okay, talk with the provider about fracture reduction and medication to develop a treatment plan that is right for you. All right. Now, no clinical factors, no skepticism about medication treatment is perfectly appropriate. I have a doctor that will discuss your plans if you are scanned or diagnosed with osteoporosis, and you can actually consider medication treatment as well as non-medication interventions such as physical rehabilitation or physical therapy But right now, we have so many studies on osteoporosis. We can give by bisphosphonates, calcium supplements, vitamin D combination with calcium. Those are the pharmacologic treatment. But as I mentioned, you may actually start screening less than 65 years old, not just for 65 alone, if you have an increased risk for osteoporosis. Okay, let's go now to the types of bones. As I mentioned a while ago, we have two types of bone. We have compact and cortical bone. Your compact bone composed of 80% of the total bone mass. Okay, your compact bone is also known as your cortical bone. While your cancellous bone or trabecular bone or your spongy bone are actually found in the deeper areas. They are composed of numerous interconnecting cavities that, in contrast to your um, compact bone or cortical bone, which is 80%, your spongy bone will only comprise of the 20% of the total bone mass. Okay, this is a good illustration on how your compact bone, that is your cortical bone, compared to the 20% of the cancellous, trabecular, or spongy bone. Okay, that cancellous bone, this is in combination with the bone marrow. Okay, the bone marrow. That is where all the bloodlines are originated. Okay, so going back here in this illustration, from this tip of the pointer, so as we learned kanina, this is the periosteum, the bone covering. From the tip of the pointer right here up to this area is your compact bone. And this whole area is actually your spongy bone or your trabecular bone. And that only comprise of 20%. Okay. This will not be included in your examination, but this is worth mentioning. This is tackled during your skeletal system lecture in gross anatomy. We have long bones, short bones, and flat bones. Yeah, but in microscopic human structural biology, bone organization is actually important. And there are two types of bone organization. We have lamellar bone and non-lamellar bone. Okay, lamellar bone first is actually a bone organization in adults. It's either you have a compact or a spongy bone, and they are characterized by multiple layers or lamellae of calcified matrix. Lamellae are organized either parallel to each other or concentrically around the central canal. And there are four types of lamellae, which we'll be talking about in a little bit later. Type 1 collagen fibers are aligned in parallel in each lamellae. As of this time, you have to take note that bone has type 1 collagen fibers. Okay. Now, basically, the lamellar bone is the compact and spongy bone, and it is composed of lamellae of calcified matrix. Okay. In the compact bone, we have the osteon or Aversion system. And as mentioned a while ago, Aversion canal is composed of blood vessels, nerves, veins, loose connective tissue, and endosteum, which is composed of your different types of bone cell linings. Okay. The lacunae is a structure in which your osteocyte is lodged. No? And as mentioned a while ago, your bone caniculi is your finger-like projection that is found in the osteocyte. Okay, this is osteon or the Aversion system. This is Aversion canal, or we may call this one essential canal. Lacunae is the structure. The cell pointed is osteocyte. Okay, in the practical exam, if this one is pointed, take note of the question. If the structure identify structure pointed lacunae, cell pointed osteocyte. Okay, cell pointed osteocyte. What is the function of the cell pointed? Your answer would be it maintains bone matrix. Okay, identify the structure pointed, the finger-like projection. Those are your bone canaliculi, and identify the function of that finger-like projection, communication, or conduit between osteocytes. Okay, Doc, what is this concentric lamellae? All right, concentric lamellae is let's put it this way. Lamellae is this one lamellae another lamellae, another lamellae. This L is lamellae, no, not lacunae. One lamellae, another lamellae. Can you see? No? Did you understand? The laminae, we call concentric lamellae if it is surrounded in the central canal. Okay? The lamellae, but if this one is surrounding the central canal, it is specifically called your concentric lamellae. And there are three other types of lamellae which will be discussed in a while. Okay? Okay, what else that we need to know in the Aversion system or osteon? It is a long cylinder parallel to the long axis of the diaphysis, and they are more collagen rich. And we have the so-called Volkmann's canal. Your Volkmann's canal is actually a perforating canal, and that canal communicates with another central canal. So basically, if this one is a one Aversion system, and this is the central canal, the structure that is being pointed right now is actually your perforating canal or your Volkmann's canal. No, they communicate one Aversion system to another Aversion system. So basically, if Aversion systems are involved, it is your Volkmann's canal. But if you look closely here, if the osteocytes communicate with another osteocyte, it is actually your bone canaliculi. Okay? One osteocyte to another osteocyte, bone canaliculi. If it is one central canal or one Aversion system to another Aversion system, it is called your Volkmann's canal. Volkmann's canal or perforating canals. All right, in this picture, we've talked about the concentric lamellae. In this slide, we'll be talking the rest of the lamellae. As mentioned a while ago, if the lamellae is organized around the central canal, it is called concentric lamellae. But what if your lamellae is found between an intact osteon? So let's go back to this picture. This is one osteon. This is another osteon. This is another osteon or Aversion system. The lamellae that is found in between an intact osteon is what we call or term as your interstitial lamellae. Okay? Para hindi kayo ma-confuse sa concentric and interstitial. Concentric sa loob ng Aversion system. If it is found outside or if found between an intact osteon, it is our interstitial lamellae. Your external and inner, what is the difference of that? External is located immediately beneath the periosteum. And as you all know, the periosteum is found outside, thus the term external. Your inner or internal circumferential lamellae is found around the marrow cavities. And as you all know, the marrow cavities is found more deeper than the compact bone. No? Picture. Okay, sorry. Now, this one is the external circumferential lamellae, meaning they are found more of outside. That's the term external. The internal here, the internal circumferential lamellae are found in the or near the marrow cavities. That's the term internal. Okay, so you have to take note the different types of the lamellae. All right, so as mentioned a while ago, there are two types of bone organization. One is lamellar, the other is non-lamellar. And this is known as your woven bone. They're usually temporary. That is comprised of a random distribution of still type 1 collagen, but you have to take note of the red one. This is the first bone tissue to appear in embryonic development. And please take note, they are the first one to appear in fracture repair. Okay? They are involved in fracture repair. Thus, they are usually temporary. Okay? They are being replaced in adults by lamellar bone, and they have a lower mineral content, and they have less strength than your lamellar bone. Obviously, because they are usually temporary. Okay? So there are two types of bone organization. Let's go to the two types of growth. No? The appositional growth is growth in circumference, basically. While your interstitial growth, as opposed to your appositional, they are growth in length, right? Growth in circumference, Appositional. Interstitial is growth in length. Okay, what about development? We have two types, your intramembranous and endochondral. The main difference is that, look at the intramembranous. The osteoblasts, as you all know, they will differentiate directly from the mesenchymal cell or the osteoprogenitor cells and begin secreting osteoid. No? And this is the type of bone cells that we've discussed in the first part of the lecture, intramembranous. What about the endochondral? The endochondral is defined as the pre-existing matrix of hyaline cartilage is eroded, okay, and they were invaded by the osteoblasts, which begin osteoid production. Ito, alam na natin na osteoblasts will begin osteoid production. But in the endochondral, there is a pre-existing matrix. No, the erosion of this pre-existing matrix will be invaded eventually by the osteoblast, and this is what we call your endochondral ossification. Okay, let's discuss, apply this in medicine. Your osteogenesis imperfecta is also known as your brittle bone disease. This is a group of related congenital disorders. Now, as definition or as defined, osteoblasts produce deficient amounts or they have defective type 1 collagen due to a genetic mutation. So this is an example of your osteogenesis imperfecta. It is genetic. No? As you can see, this is the mother which carries the gene that is being passed through by her 3 children. Okay, this is actually, ito lang, I just made it myself, the ABCDEFG of osteogenesis imperfecta. It is an autosomal dominant. The patients here has blue sclera. C would be collagen production impaired, type 1 specifically, deafness, easy bruisability. F would be the fragile bone or if they are fracture prone, and G is the genetic disorder. So I hope this one helps you in studying the osteogenesis imperfecta. Okay, now let's move on to the second part of this lecture. You have the cartilages. Okay, your cartilage is a tough and flexible connective tissue. It is composed of an extracellular matrix. The GAGs or the glycosaminoglycans and proteoglycans interacting with each other interacts with collagen and elastic fibers, and they forms from an embryonic mesenchyme. Just like the bone, they form from embryonic mesenchymal cells. Okay? So galing din yan sa mesenchyme, and as you all know, the mesenchyme in the bone is also known as the osteoprogenitor cells. Okay, so basically, this is a summary of the 3 cartilages that we will be learning today. These are the hyaline, the fibrocartilage, and the elastic cartilage. I'll help you memorize all these things. Okay, now look at this picture, class. If you notice, the blue ones are actually the distribution of your hyaline cartilage. They are found in the costal cartilage, the articular cartilage of the joints, where else also actually in the joints, the hyaline cartilage, they are found at the respiratory tract cartilages. You have the larynx, the trachea, and of your in the lungs. Okay, your your elastic cartilage, that's the second type of cartilage. Look at the elastic cartilage. They are found in E. Okay, E as in elastic. They are found in epiglottis and in the ears. Okay, daling tandaan, di ba? Elastic cartilage, ears, epiglottis, because they are composed not just the collagen fibers, but also E, elastic fibers. Okay, that's the clue there, E. And the last one would be the fibrocartilage. They are primarily located at the pubic symphysis and the intervertebral disc. Now, let's talk about the functions in general of the cartilage. They forms the framework, no, supporting soft tissues. They also provide a shock absorbing and sliding area for joints, as seen in the previous slide, yung distribution of cartilage. They facilitate in bone movement, and they are also essential for the development and growth of bones before and after birth. Okay, general characteristic. Number 1, cartilages are avascular, meaning they don't have vascular or blood supply. So the nutrients are received by the diffusion from your perichondrium. Perichondrium we will be talking about that in a little later. They have low metabolic activity, the cartilages, and take note, as opposed to your bones, they don't have lymphatic vessels and nerves. Okay? So basically, no nerves, no vessels, no blood supply. Their nutrients are received from the perichondrium. Okay? Now, if bones has osteocytes, your cartilage also has chondrocytes. Your chondrocytes, take note, they synthesize and secrete the extracellular matrix, right? They're also located or lodged in the matrix cavity, just like your bones with this lacunae. Okay? Again, chondrocytes are lodged in the lacunae. Your osteocytes are lodged also in the lacunae. May isa lang type of lacunae, the house shaped lacunae, which your osteoclasts are lodged into. Okay, Doc, what is extracellular matrix? Now, basically, the extracellular matrix is composed of fibers, either collagen and elastic fibers found in the cartilage, and also, as mentioned a while ago during the introduction of cartilage, the gags and protoglycans that will make up your ground substance. The fibers and the ground substance, yan ang composition ng extracellular matrix. And who synthesize and secrete that extracellular matrix is actually the chondrocytes or your cartilage cells. Okay, this one is taken from Junquera. Now, this one is your type 2 collagen fibril. Actually, kapag cartilage type 2, pag type 1, collagen bones. Okay, so this is the hyaluronan link protein. Where else? The core protein, and this one is the collagen type 2, and this is an example of your chondroitin sulfate. If that extracellular matrix and fibers combine, that will make up your extracellular matrix. Okay, sorry, your ground substance is made up of these GAGs or glycosaminoglycans or hyaluronan and your proteoglycan in combination with the collagen elastic fibers that would make up your extracellular matrix. And what synthesize and secrete that? It's the cartilage cells. Okay. Okay, let's talk about the types of cartilage one by one. The most abundant is the hyaline cartilage. And as I mentioned a while ago in the pictures, the distribution of the cartilage, these are the locations of your hyaline cartilage. Articular surfaces of a movable joint, walls of larger respiratory passages, your ventral ends of the ribs articulating with the sternum, your epiphyseal plates of long bones, and the embryo, there are temporary skeleton that is replaced by bone. If you notice, okay, in the embryo, there are temporary skeleton replaced by bone. This is known as your endochondral ossification. No, basically, they are at the cartilage first that is being eroded by the osteoblast, and then they will synthesize the osteoid, and that is your endochondral ossification, right? So yeah, these are the locations of your hyaline cartilage. Okay, now basically, this one is your hyaline cartilage. It is characterized by having a ground glass appearance of the bone of the extracellular matrix. No? Maganda yung distribution ng mga cells. These cells actually are your chondrocytes or your cartilage cells. No? P here stands for your perichondrium. Diyan po galing ang nutrients. Magkabila yan. P, perichondrium. Diyan galing ang nutrients ng matrix. Okay, ng extracellular matrix. Now look at this closely. Your chondrocytes or your cartilage cells are your parenchyma of your cartilage. Okay, the shape of which they are arranged in singly, like this one, or in isogenous groups, in three, like three, this one, ito, mga isogenous groups yan. No, singly or single, S-I-G-L-Y, or in isogenous groups. Okay, the matrix, as mentioned a while ago, they are composed of collagen, mostly type 2. The most abundant proteoglycan is your aggrecan. No, And the chondronectin are multi-adhesive glycoprotein which binds to the gags and collagen type 2 for it to become adhered to the chondrocyte to become extracellular matrix. Okay? So ganyan kailangan may gags or glycosaminoglycans and may collagen type 2 to become extracellular matrix. Your chondrocytes are mentioned a while ago. They're arranged in singly or in isogenous group. And as mentioned, they are lodged in the lacunae. Where our chondrocytes come from? They come from the chondroblast. And this young chondrocytes, they're elliptical in shape and they are found in the periphery of cartilages. Actually, they are found in the perichondrium pa. This is a chondroblast. This is in the perichondrium. If this chondroblast becomes mature, it goes down to your matrix, becoming your chondrocyte. Okay? And take note, okay? The perichondrium is a layer of dense, irregular connective tissue. Okay? Take note, okay? Perichondrium, if asked what is the fundamental type of tissue of the perichondrium, you'll answer connective tissue. What is the subtype? It's the connective tissue proper. And what is the specific subtype? It is a dense, irregular connective tissue. Okay? Doc, lahat po ba nako-cover ng perichondrium? It covers all hyaline cartilage except the articular cartilage. Take note of this. Covers all hyaline cartilage, the locations of hyaline cartilage except the articular cartilage. Okay, this is a picture of a trachea. No, this is taken from the laboratory. This is your lining epithelium. This is the layer, lining epithelium, lamina propria. No, this is the submucosal layer, and they are comprised of your tracheal glands. And this one actually is your tracheal cartilage or your hyaline cartilage. Now, if this one is your high power magnification, showing you the different chondrocytes found in the matrix. They're in singly or in isogenous groups. Now, what is this class? This is the layer of a dense irregular connective tissue called your perichondrium. Chondroblasts are here. Now, once they become mature, it goes to your extracellular matrix. The characteristic of the hyaline cartilage is the ground glass appearance of your extracellular matrix. Maganda. No? We will be comparing this to the elastic cartilage in a while. Okay? Yan. So this one is in highest magnification, showing your chondrocytes arranged in singly or in isogenous groups. Okay? And singly, actually this is an isogenous groups. Okay, singly or in isogenous groups. Okay, as compared to your hyaline cartilage, your elastic cartilage, they're actually similar, but they have abundance of elastic fibers. They also have collagen type 2, but they have abundance of elastic fibers. Where are they located? As mentioned, elastic fibers, elastic cartilage. They are found in the ears, the auricle in your ear, the external auditory canal, auditory tubes, and your epiglottis, except for the the cuneiform cartilage in larynx. Okay, lahat yan, they are found in those locations, the elastic cartilage. Now, this is a picture of your hyaline cartilage. No, look at the ground glass appearance of your bone matrix, of the extracellular matrix in the hyaline cartilage. Now, look at the elastic cartilage. What do you notice? The fibers here are, they appear dirty as opposed to this homogeneous extracellular matrix of the hyaline cartilage. Okay, what else? Yun, fibers ng elastic, no? Medyo talagang madumi, ano? Dirty looking appearance. Take note of the chondrocytes in both of the hyaline and in the elastic. They're actually the same. No, they are arranged in singly or in isogenous groups, and they are lodged also in the lacunae. Okay, so this is taken from Junquera. These two pictures, the hyaline and the elastic cartilage. Please take note of their differences. This is the epiglottis in the laboratory. Okay? They are lined by stratified squamous non-keratinized epithelium. What else? So this one right here is your perichondrium. This one right here is also the layer of a perichondrium. And as mentioned a while ago, they are a layer of a dense irregular connective tissue. Okay. Now, from this tip of the pointer up to this area, that's the whole elastic cartilage that is found in the epiglottis. Sorry, the organ in focus right now is epiglottis. They are characterized by having a abundance of elastic fibers. Look at these fibers. They really appear dirty or in disorganized manners, but also they have collagen fibers, not type 2 collagen fibers. This is a high power magnification of the elastic cartilage showing you the elastic fibers. Okay, as similar to the hyaline cartilage, they have also chondrocytes that are arranged in singly or in isogynous groups. Okay, so those are the difference and similarities of hyaline and elastic. Okay, and the last type of cartilage would be a combination of hyaline and dense connective tissue. This is known as your fibrocartilage. Okay, the chondrocytes. Okay, the chondrocytes here are smaller and they are arranged singly or in isogynous aggregates. Now, pakipalitan. Okay, if your hyaline and elastic cartilage, they are arranged in singly or in isogynous. The fibrocartilage, para uniform tayo, they are arranged, no? The chondrocytes are arranged in rows. Okay? Don't answer singly or aligned in isogynous aggregates. They are arranged in rows. All right? They produce type 2 collagen. Now, where are they located? The fibrocartilage, as mentioned a while ago, they are located in the intervertebral disc and in pubic symphysis. All right? In the laboratory, we usually use this slide. No, this is your intervertebral disc. No, the cells pointed right now are actually your chondrocytes, and they are arranged in rows. Okay, they are arranged in rows. They have collagen type 2 pa rin, but the arrangement of the chondrocytes here are in rows. This is your intervertebral disc. Okay. Now, what is the most important thing that you have to know in the fibrocartilage? They don't have identifiable perichondrium. No, um don't forget about this. Naka all caps na, naka red pa. No identifiable perichondrium in the fibrocartilage. Um, while hyaline and elastic, they do have perichondrium. Okay? All right. Yeah, so we've discussed the three types of cartilage. Now, this is just a summary picture of the hyaline cartilage, your elastic cartilage. Compare this one. Hyaline has homogeneous extracellular matrix, while your fibrocartilage has dirty looking as opposed to your hyaline. And the fibrocartilage, yan, they have lacunae in lacunae. They have chondrocytes lodged in lacunae. They are arranged in rows, the chondrocytes, and they don't have perichondrium. Okay. Take note also the locations of the different cartilages, the hyaline, the elastic, and the fibrocartilage. All right. Also, just like the bones, your cartilage formation would be coming from the embryonic mesenchyme. Okay, these are your mesenchymal cells. That's the precursor of all types of cartilage. Now, during mitosis, letter B, mitosis and differentiation, this will become your chondroblast. They are separated from one another, and then they will become your chondrocytes here. They are arranged in isogynous group. Some are in singly. So hanggang dyan. So from the mesenchymal to chondroblast to chondrocyte, and from forming an isogynous group, that is your formation of your cartilage cells. Okay, what else? Two types. You have the interstitial and the appositional. Just read on that. But I have to end. Ito pa in medicine, no? They have chondroma, which is a benign tumor, and the chondrosarcoma, obviously, because of the term sarcoma, that becomes a malignant type of tumor. But they are slowly growing, they seldom metastasize, and they are easily removed by surgery. Okay? Why? Why is it that they are slowly growing? As mentioned a while ago, they don't have blood supply. Vascular supply for the tumors are very much important in neoplastic tumors or in malignant proliferation. Kaya madaling tanggalin. No? They're easily removed by surgery because they're slowly growing. They don't have vascular supply. Okay? Yeah. So please take note of this table. Okay. Now, basically, we have discussed these three cartilages, the hyaline, the elastic, and the fibrocartilage. Now, let me just emphasize on this one. Now, the presence of perichondrium, yes, except for the articular cartilages, all elastic cartilages, they have perichondrium, no identifiable perichondrium sa fibrocartilage. Main locations, as discussed a while ago, please take note. But the main function, no, I want you to take note of this. Your hyaline cartilage, their main function is to provide smooth, low friction surfaces in joints. That's why all joints, they have hyaline cartilage. They're also structural support for respiratory tract. I'm talking about trachea and the inner lungs. They are all hyaline cartilage. What about elastic cartilage? Elastic cartilage, they provide flexible shape and support of soft tissues, while your fibrocartilage, look, they provide cushioning, tensile strength, and resistance to tearing and compression. Okay? I know generally speaking, they provide support, but please take note of the individual function of each cartilages. Okay? All right, so that ends the lecture on bones and cartilages. Thank you for listening, and if you have queries, feel free to message me anytime. Thank you.